Good afternoon, and welcome to the September Simon Says Expert Series. I'm Dr. Antwione Haywood. I serve as the Chief Diversity Officer for the Cancer Center and the Associate Director of Diversity, Equity, and Inclusion. I also have the pleasure of being the Assistant Dean for Medical Student Affairs and an Assistant Professor of Radiation Oncology with the IU School of Medicine. Our experts today are Doctors Siethal Jacob and Andrew O'Brien. They will discuss sickle cell disease and how they are working together to conduct precision research that improves sickle cell care in Indiana. Just as a little background for myself, I've had the pleasure of working with these two scholars to really advance this work. And this is a topic near and dear to me. So for those of you who don't know me that well, I had a daughter at the beginning of the pandemic. And, like many babies, they get a series of tests. And we actually got some information back from the Department of Public Health indicating that she had the sickle cell trait. And we begin to worry and just wonder, what does this mean? And I'm really happy to have exciting researchers like this who I can go to and ask all the questions I have just about what this means for my daughter and those who follow her. So Dr. Jacob, primary area of research interest is in healthcare access and delivery for patients living with sickle cell disease, with a particular focus on implementation of health interventions. Through an award from the National Heart Lung Blood Institute, she's seeking to develop and evaluate telemedicine models for the delivery of sickle cell care in Indiana. Dr. O'Brien's vision is equitable, agile healthcare for all. His mission is to revolutionize the way we partner with those living with sickle cell disease by building comprehensive systems of care based on a lifespan approach, and to acknowledge the impacts of systemic racism and social determinants of health. Thank you, Drs. O'Brien and Jacob, for joining us today. And I'd like to invite you to share some welcoming words and to present some opening information about sickle cell disease to our audience.
Thank you so much, Dr. Haywood, and thank you for the Simon Says team for bringing us here today, and thank all of you for joining us. This is truly something Dr. Jacob and I are extremely passionate about, is truly our mission in life. So I think it's worth starting by asking, why sickle cell disease? Why are we talking about sickle cell disease? What is sickle cell disease, and why are we bringing it up in a cancer center forum? As it might at first glance not seem terribly obvious that it's the right fit, but in the end, I think it really is. So just briefly, sickle cell disease is an inherited blood disorder related to a molecule called hemoglobin, which is inside the red blood cell. It's actually what the oxygen sticks to and what the red blood cell uses to carry the oxygen around. So sickle cell disease is a mutation, a genetic mistake in that gene for the hemoglobin molecule. That can lead to a variety of clinical manifestations, from less impactful things like sickle cell trait, as Dr. Haywood mentioned, to very severe manifestations and the more severe forms of sickle cell disease. So about 7% of people in the world carry a mutation in the hemoglobin molecule of some kind. Specifically, sickle cell disease affects about 300,000 births each year. And one out of every 365 African-American births, and about 1 out of 12, as Dr. Haywood mentioned, will have sickle cell trait. Also in the Latinx American population as well. So this is the most common inherited hematologic condition, as well as the most common genetic disease found on the newborn screen. So for instance, as Dr. Haywood mentioned, this is something everyone born in Indiana is screened for on their newborn screen. And so the implications of this are quite broad and quite significant, even though genetically it's really a very simple initial problem. The downstream consequences of that are quite significant. So why sickle cell disease? Where did that name come from? It actually comes from the way the blood cells end up looking under the microscope. So if you look here, this is a picture of blood cells from an individual affected by sickle cell disease. You can see on the blue arrow there, that's what a healthy red blood cell should look like. Sort of like that donut shape where it's nice and round with a little central area of clearing in the middle. But if you look at the red arrow there, that's a cell that has sickled. And so what happens is the sickle hemoglobin molecules, that mutation makes them sticky. And so they stick to each other and form big, long chains. Normally, these molecules are just floating around inside the red blood cell, but in sickle cell disease, they stick to each other, which then causes them to form these big, long chains, which pushes on the sides of the red blood cells. So this is where the name came from, that when they first started learning about this disease, when they looked under the microscope at the red blood cells, they saw these sickled shapes, and that's where the name came from. But it's unfortunately much more complex than that. So the initial thinking decades ago was that these sickled red blood cells just sort of got stuck in something that's called vaso-occlusion. Vaso meaning blood vessel, occlusion meaning blocked. So the blood cells were literally just getting stuck inside the blood vessels. And the initial thinking was that that was sort of the end of it, that the blood cells got stuck, everything downstream of that wasn't getting enough blood supply, it got low oxygen levels, caused damage to the tissue, pain, etc. But as we've learned more, sickle cell disease is actually much, much more complex than that. It's not just the blood cells getting stuck. The blood cells also become very fragile. They break open in something called hemolysis. So hemo, blood, lysis, breaking apart. So the blood cells break apart, and everything that's supposed to be inside the blood cells spills out into the bloodstream. Normally, our bodies have very delicate balance of what's inside the cells and what's outside the cells. But in sickle cell disease, due to the damage to the red blood cells, that very delicate balance gets lost. The balance of the normal blood chemistry gets lost, which has significant implications on how blood functions, how organ functions. And also, both of these things lead to a lot of inflammation. Sickle cell disease has significant amounts of inflammation, of white blood cells being activated, of damage to the blood vessels themselves. And then all of these things sort of compound and interact in ways that we are just, I think, starting to learn how little we truly understand. That the interactions of all of these things are very complex, and there's a lot of unknowns about how one interacts with the other and how those then lead to the problems that we see with the patients living with sickle cell disease. But all diseases are so much more than just their physiology, than so much more than just what's happening to the cells, right? These all occur in people. These are all people trying to live with a disease, live and thrive as best they can. And in sickle cell disease, it is heavily skewed towards the African American and to a lesser degree Hispanic populations. And so it is essential that we acknowledge the context in which these people have to live. That there's a context of racism and the impacts of racism, as we can discuss more on research funding, on how our patients are perceived and approached. The fact that these populations are already dealing with significant social determinants of health. And then when you add on top of that a chronic disease, that we don't have the appropriate infrastructure generally to manage adequately, that there's significant stigma, both within patients' own communities, as well as external communities, as well as what are called cycles of mistrust, where our patients, as a result of the racism and stigma that they have encountered in their lives, try to adapt and cope, and sometimes do that in somewhat maladaptive ways, that then lead healthcare professionals to interact with them in maladaptive ways, which then further reinforces the distrust and the stigmatization, which then further reinforces maladaptive coping mechanisms. And you get into this unfortunate cycle where nobody sort of trusts anyone. And trust is essential to providing good medical care, to really all human interactions, but certainly what we try to do as healthcare professionals, trust is really the foundation upon which we have to try to build the way we take care of people and partner with people in their care. But unfortunately, due to the sort of historical context in which sickle cell disease has grown up, there's a lot of other societal implications on top of what, as I said, was a very complex physiologic disease. I'm going to turn it over to Dr. Jacob to talk a bit more about the physiology and what things look like as our patients try to live their lives.
Thanks, Dr. O'Brien. So the complications of sickle cell disease, as you can imagine, can encompass anything that the blood would touch. Because it affects the hemoglobin inside of the red blood cells, as Dr. O'Brien explained, it means it can touch anything that our red blood cells touch in our body. So we see complications such as strokes, retinopathy, or complications of the eye that can lead to blindness. You can see liver dysfunction. You can see complications in the spleen that lead to an increased risk of certain bacterial infections, leg ulcers, and many more that are listed here on this figure. But the most common complication that we see in sickle cell disease is actually pain, very severe pain that can happen suddenly and not in a very predictable fashion. And the pain can be so severe, we've certainly had patients describe it as shards of glass piercing through their veins. And because of how unexpected it can be, can lead to a significant disruption in sort of daily life. This graph right here is actually to illustrate the number and severity of disease complications seen in sickle cell disease, certainly increase with age. This is just showing you 5 of the most common that we see in sickle cell, but there are many more, as the previous figure showed. And with time, as more damage is done from the sickling red blood cells, the breakdown of those red blood cells, and the inflammation, as Dr. O'Brien explained, the more complications that we see. This is a really important figure, especially as we talk about how our patients live with sickle cell disease as a chronic disease. At the top of the graph is colored in green are children living with various diseases. And at the bottom of the graph, colored in yellow, are adults living with various diseases. And you can see across the spectrum, we're talking about quality of life. So how do individuals living with different diseases or disorders report their quality of life? And children living with sickle cell disease actually report a very similar quality of life to children that are on treatment for cancer, and actually a worse quality of life than children that have completed cancer therapy. And on the bottom, you can see that adults living with sickle cell disease actually report a worse quality of life than adults who are being treated for cancer, and worse quality of life than adults living with cystic fibrosis, another inherited chronic disease condition. And a lot of this speaks not just to the complications that they experience, but also to the other aspects of living with a chronic disease in our healthcare system that Dr. O'Brien mentioned: the social determinants of health, the racism, the mistrust in the medical system. All of that contributes to the quality of life that our patients with sickle cell disease are experiencing.
Wow, thank you for that. I'm just reflecting on this idea of how our red blood cells touch everything and how it impacts our body. And I'm noticing the overlap with the aspects of quality of life, but then thinking about how a person can live from childhood through adulthood with sickle cell disease. So you may know that this is our 30th anniversary of the Cancer Center, and our theme is accelerating cancer research. And much like a great auto team, it's all about precision, working together, identifying root cause problems and addressing and ultimately to improve the race. And when you think about sickle cell research, how do we have to approach sickle cell differently from other cancers or from cancers generally? And perhaps where is there some opportunity where people might see benefit in focusing on sickle cell as a neglected area or an area of focus?
Yeah, that's a great question, right? The reason sickle cell disease ends up in cancer centers, and that's sort of the general trend if you look across the country, is because there is a lot of the right expertise is really inside the cancer center, right? The expertise in blood function and blood disorders is just historically all sort of wrapped up with cancer treatment and cancer care, right? The way we are trained as physicians, cancer and blood disorders, the training is sort of linked and done together. And if you look at the treatments we have currently for sickle cell disease, there's tremendous similarities between sickle cell disease treatment and cancer treatment. Things like hydroxyurea was actually initially developed as a cancer treatment and was then found to improve the way blood functions in sickle cell disease. It was the first thing we found that actually affected how the underlying problem, how the underlying blood function can be improved to help people live longer with sickle cell disease. Things like monoclonal antibodies, so artificially constructed antibodies. There's now one available for sickle cell disease. These were initially developed for cancer treatment. Things called small molecule inhibitors. We have something called voxelotor, which actually gets in the way of that stickiness between the hemoglobin molecules. And again, small molecule inhibitors like that are commonly used in cancer care. Things like stem cell transplant and other advanced cellular therapies about trying to reprogram the way our blood cells work. Those things are a lot of them are outgrowths of cancer treatment, and there's a lot of overlap in the expertise and the logistical support and the resources needed to provide these kinds of advanced therapies. So there are a lot of ways in terms of the physiology, in terms of the treatment expertise, where sickle cell care and cancer care overlap very nicely. But I think there are some key pieces, key differences that we have to keep in mind when we try to approach sort of comprehensive sickle cell care. One obviously is the sort of environment in which our patients work. But unfortunately, again, minority populations with cancer care, there are a lot of issues with access and inclusion in clinical trials. And so those sorts of historic inequities are present in both, with the difference that the majority of our patients with sickle cell disease belong to those minority and marginalized communities. Whereas cancer sort of extends to all groups. But certainly there are some themes about equity and addressing the impacts of historic systemic racism and current systemic racism. But it's important to remember that I think, again, I trained in cancer care as well. I don't do much of it anymore, but cancer generally is sort of this period of time, right, where you're diagnosed with cancer and there's generally this sort of intensive treatment period. Depends a lot on the cancer, but it's sort of this time compressed thing, right, which I think significantly changes the way you can approach things like clinical trial enrollment, the kinds of trials you can do, right? There's sort of this mentality of, this is the cancer, I'm going to try to focus on this, deal with this, do clinical trials, get my treatment, whatever, with the hopes that eventually getting back to sort of, your typical life. Our patients are different, right? This is something they're born with. They've lived with it their entire lives. And so I think that adds additional challenges to recruiting for clinical trials and organizing clinical trials, that there isn't sort of this, I'm just going to stop and drop everything and try to focus on dealing with my disease, because it's something they have to deal with every day. They grew up with it every day. And so it's just, it requires, I think, thinking differently about how we approach research than sometimes the way we think about approaching cancer research.
Yeah, so let me ask you a question there. So, I notice we're all twinning today. Everyone has on their Sickle Cell Matters shirt. I don't know if our audience can see that, right? So for those out there, they may not understand, when it comes to, clinical trials and access to funding, why does sickle cell matter? And, what are some potential disparities in funding relative to, say, similar diseases or diseases within, or, diseases that can serve as a reference point?
Yeah, absolutely. Thank you for asking that question. And Dr. O'Brien, if you can actually pull up this figure right here, which I think really clearly depicts the disparity in funding for sickle cell disease compared to cystic fibrosis, as I mentioned, another inherited chronic condition from childhood. And a major reason why we see sort of the limited therapeutics and the perspective of sickle cell disease being a neglected disease is there's this real lack of investment in research funding for patients with sickle cell disease. So in this chart, in blue, you have patients with sickle cell disease, and in red, you see sort of funding for patients with cystic fibrosis. And you can see based on the proportion of patients living in the US with either disease, NIH or federal funding versus foundational or philanthropic funding really is not in line. So on average, in the US, we spend less than $1,000 per person living with sickle cell disease on research versus over $10,000, close to $11,000 on each person living with cystic fibrosis in the US. A huge gap. That's about a 1,000% difference in the amount of funding that's spent. And you can see as a result of that, we've had limited research related to new medications for decades. I think we've seen significant improvements over the past 5 to 7 years with 3 new FDA-approved medications in the last 4. But we've got a long way to go, not just related to research about medications, but also improving access to care, improving the quality of care that we provide, understanding what combinations of medical treatments are best for our patients with sickle cell disease so that they're not just good in this moment, but they're feeling great throughout their lifetime. Things that improve their lifespan and the quality of life that they're living. All of that is an important part of research and research that needs to be funded.
And I think it's important to also understand sort of the downstream implications of that in terms of getting resources to provide care. Because we can get sort of stuck in these cycles of inequity where, because there was historically such a dramatic disparity in research funding, that has then led to significantly less medications available for treatment in sickle cell disease compared to cystic fibrosis, which then has the downstream consequence of generating less revenue for the health system, right? Medications can be very expensive. They can make a lot of money for the health system, which then makes it easier for the health system to provide resources to take care of people. But we're sort of stuck in this because we didn't have the historical investment in research that has led to many, many sort of expensive revenue generating medications. We then are stuck in a place where it's much more difficult to get resources to help provide the excellent care our patients need, because there simply is not the sort of downstream revenue to pay for those things, which then makes it harder to provide clinical care. It makes it harder to provide access to research to try to undo the inequity. And so we're sort of stuck in this cycle where, because of historic inequity, we're continuing to perpetuate future inequity.
Wow, wow, very powerful. So it sounds like nationally, we're struggling to provide the precision and excellence we need in order to advance treatment with this particular disease. And speaking of excellence, so IU, Simon, is known for developing what are referred to as centers of excellence. And some may know about the Brown Center for Immunology or the Vera Bradley Center for Breast Cancer Care. And it would be interesting to understand what IU is doing to make a difference. And perhaps, maybe you give us some insight if you're working on a center of excellence.
Yes, so thank you, Dr. Haywood. So as Dr. O'Brien mentioned earlier, we are both very passionate about sickle cell disease and for improving the care that our population here in Indiana and nationally receive. I think we are lucky to have teams that work with us and individuals around us who support us in that passion and support our patients in that endeavor as well. So we, with the support of the Simon Cancer Center, are actually developing a center of excellence for sickle cell disease at IU. The focus is that it is a lifespan center of excellence. So from childhood to adulthood, focusing on the quality of care, innovative care, and access to care for our patient population. And you can see that the focus is really sort of threefold, not just the clinical care or the medical care that we're providing every day, making sure that not only is it excellent, but it is innovative, but also in ensuring that we are focused on research and education, making sure that our patients have access to clinical trials, that we are being novel in sort of the therapies that we provide, and increasing the research funding that's available for sickle cell disease here at IU, but also ensuring that future generations within healthcare are invested in improving the care of our patient population, both within the state and around the country and globally as well. And then from a community engagement standpoint, we are working with our sickle cell community-based organization, the Martin Center Sickle Cell Initiative, to ensure that we are providing care, excellent care, but care that's also relevant and important to the individuals that we serve, and focusing on statewide advocacy, utilizing platforms like Simon Says and others to help people become aware about sickle cell disease, to help them understand why it's important to support individuals living with sickle cell disease and what they can to improve the care that they have.
And I think trying to leverage all of the incredible things happening, and IU is a fantastic institution, but I think sometimes due to its size, sometimes it's hard to know all of the great things that are happening and stay connected to everyone that's doing amazing things relevant to what you're doing. And so, right, that's one of the foundations of the Center of Excellence, is to bridge all of these different places, whether that's the statewide reach of IU Health, whether that's the operational excellence of the Cancer Center, incredible research happening at IU, both currently in sickle cell disease. We have 2 R01 funded researchers in basic science in sickle cell disease, as well as a fantastic acupuncture trial by a faculty in anesthesia, but also sort of areas where we can potentially grow collaboration. IU has a world-renowned gene editing facilities that that's a very promising avenue for sickle cell disease treatment, editing the genetics of people's own blood cells to produce healthier cells. So I think there is fantastic opportunity both at IU, and as Dr. Jacob mentioned, the Martin Center is actually one of the oldest community-based sickle cell organizations in the country, has been around, I believe, since the early 70s. So we really have deep roots and fantastic things happening here. We just need a place to bring all of these incredible things together. Right, just as the Cancer Center does for cancer care, it really needs to be about interdisciplinary research, interdisciplinary clinical care, interdisciplinary advocacy, because we are all so much more powerful when we come together and we bring the areas of various strength together to focus on the same goal.
Very nice, thank you. So I'd love to understand a little bit more about access to care in the state and sort of where the needs are and what we're doing within the state to address that.
Absolutely. And this is an area that I really love and I'm passionate about. And while I support and find very significant sort of the innovation and the need for innovation in sickle cell care, I also recognize that regardless of what we discover, if we can't get it to our patients in a way that makes sense for them, it's not going to benefit them very much. So if you look at the map on the left-hand side, this is a map of what's considered medically underserved areas in the state. And in red and green are highlighted areas, primarily primary care or other sort of primary services like dental health or mental health, where the population does not have enough providers. Obviously, this does not show kind of where providers who care for patients with sickle cell disease live, but we know that there's about 5 sites in the state that provide expert sickle cell care. And so if we were to look at populations being medically underserved from the perspective of having access to expert sickle cell providers, the majority of this map would actually be shaded in red and green. The map on the right is actually a state map that shows IU Health, the IU Health hospital network. And you can see that IU Health actually has quite a far reach, and it really tries to serve the entire state. However, there are still spaces where it's not easy to access an IU Health provider. But some of the work that we're doing at IU is looking at how can we leverage the IU Health network to expand the reach of our expert sickle cell providers. And we're doing that through the use of telemedicine. So we've had quite a bit of success in certain parts of the state, utilizing one model of telemedicine. We now have NIH-funded research to expand that to include not just 1, but 2 models, which allows us to expand the sites that we deliver that care and really allows our patients to access expert sickle cell care no matter where they are in the state. And that's important for a lot of reasons. Our research has shown that caregivers of children with sickle cell disease, for example, have 6 or more barriers on average to being able to access healthcare for their child, whether that's having multiple providers, whether that's trying to balance lost time from work and school, or the cost of transportation, especially now with gas prices being as high as they are. All of those things have to be considered for our caregivers and for our patients living with sickle cell disease, because this is something that they have for their entire life. And so we're working really hard to try to address some of those barriers, try to alleviate some of those barriers, and trying to meet our patients and families where they are in their care.
Yeah, thank you for that. And I definitely resonate with the gas piece, thinking about that all day. So this topic seems like a lot, and I'm still reflecting on, how I can make a difference, or even searching for hope around care for this population. And I wonder if there's a particular story or patient that may stand out to you that gives you hope or inspires inspires you to continue to do this good work. Do you have an example of a story we can share with the audience?
So yeah, I think again, we always try to bring it back to our patient, bring it back to our patients and what their lived experiences are, and how we can make a difference there. And unfortunately, the stories we get from our patients are pretty consistently not so hopeful ones, where our patients sort of have to bear the brunt on a day-to-day basis of all of this stigma and misconception. And one of the stories that sticks with me the most is a woman I met several years ago now, who was 39 when I first met her. And when I first meet someone with sickle cell disease, I just ask them to tell me what living with sickle cell disease has been like for them. And I'm thankful she felt safe enough to share the story of when she had first found out she was pregnant several years ago. I believe her child was around 4 at the time I met her. She was not in Indiana at the time, but appropriately was sent to a high-risk pregnancy expert. Unfortunately, pregnancy and sickle cell disease is high risk for both the mother as well as the pregnancy as a whole, and was appropriately sent to a specialist who was supposed to help guide her through her pregnancy, and help keep her and the pregnancy safe and thriving as best they can. But during this meeting, was told by the physician that she should really consider giving up her child, because she was probably going to be dead by 39 anyway, and that really wasn't fair to the child. And right, it's just the sort of arrogance and hubris of this person is staggering. But not only this doctor decided when she was going to die, he also decided it was his place to decide what was best for her and her child in the meantime. And right, and this is why the Center of Excellence is so important, that people need a place that is really for them, a place where there are people dedicated to them, people who are experts in sickle cell disease, people who are committed to helping them thrive and helping them live their lives, not standing as a barrier to them, which unfortunately is often what our patients are told. All the things they can't do, all the things to expect moving forward that are going to limit their lives, rather than focusing on how we can help them thrive and achieve whatever is important to them. And that's really our source of hope, is to build a place where every patient with sickle cell disease can live and thrive, and will not have barriers placed on them. And this is why it really, right, despite sort of it being the most common inherited blood disorder, it is still relatively rare. And this is why what Dr. Jacob was discussing is so essential, that every patient living with sickle cell disease needs expert care and needs access to people who know their disease and will know them, and help them thrive and help them learn more about their disease and how we can manage it better and help them thrive better. And luckily, there are sort of national efforts moving towards this as well. There's the newly formed National Alliance of Sickle Cell Centers. I believe there are 60 some centers now, of which we are one. And this organization is really about how do we ensure every person living with sickle cell disease gets access to expert care. And what does that even mean, right? Number one, what is expert care? How do you define that? How do you measure that? How do you ensure that? And then how do we continue to move that forward and study the things that we're doing, and ensure that we're doing things that are valuable to patients, that are helping people live longer, live better, etc. And so I think this is really an exciting time to be in sickle cell disease. Both, as Dr. Jacob said, in the last few years, there have been several new treatments approved, as well as very exciting things like gene therapy that I alluded to, But again, as Dr. Jacob so expertly put, the best treatments in the world do nothing for people if you can't get them the treatments they need. So I think this is what brings us back is all our patients that constantly have to deal with the myths, the stigma, the racism that comes with living with sickle cell disease, and just reignites our passion to build something that truly serves them better than we have been doing before.
Wow, very powerful narrative there. And certainly hear themes around relationship-centered care, access to care, and considering that person's personal experience and rooting it in their narrative. So Dr. Jacob, we have a question from the audience for you. And it really builds on what Dr. O'Brien was talking about, and it is, how do we best engage sickle cell patients in case management, and how to best manage a case for optimal results?
Yeah, wow, that's a great question. I think most important for our patients and families is to know sort of the investment we have in their care as providers, as case managers, as insurance companies. I think our patients and families have lots of reasons not to trust us or the system. And I think it's important for us to demonstrate why. And a lot of that begins with walking with them from the beginning, connecting with them regularly, finding the ways that are best to connect with them. I think back to one of our caregivers who works full time, has 3 children to care for, as well as other family members. And it's hard to answer the phone between 8 and 4 o'clock when you have to work or pick up your son or daughter from school, engage with them, especially during COVID, helping with online schooling and all of those things. So what works best for our families so that they can engage in their care? It doesn't necessarily mean they don't want to. We just might not be providing opportunities for them to engage in their care. And I think case management, working with the healthcare team, is really important. Looking at those points that patients access the health system so that you can engage with them where they are. This is similar to how we think about telemedicine, right? We are trying to meet our patients and families where they are. And I think for case management to be helpful and fully supportive of the families, that's an important part of that as well.
Yeah, thank you so much. All right, so our next question is around crisis prevention in adults living with sickle cell disease. Dr. O'Brien, do you have best practices or recommendations for any provider or nurse out there just looking to learn more about supporting patients in crisis?
Yeah, absolutely. And right, I think there are 2 sort of foundations to that in my mind. One is starting from a place of believing our patients. Right, if someone says they're in pain, at the end of the day, pain is an experience, right? I cannot say someone is not in pain. Right, sometimes we have to just have discussions around what truly are the best ways to treat the kind of pain that you're having, which can get very complex very quickly. But it really has to start from the place of acknowledging someone is in pain, they're in pain, right? Healthy people that are feeling well don't come to the hospital, right? So if someone is seeking acute care, something is wrong. Right, unfortunately, a lot of the times that's psychosocial pain, right? Homelessness, unmanaged mental health issues, right? There are lots of reasons people can experience pain. And unfortunately, in sickle cell disease, as people get older, and unfortunately older meaning, in their 20s, their pain syndromes have often become very complex, where it is their disease. But on top of that is piled mental health issues and homelessness or other significant social stressors, family stressors, right? All of these things become intertwined and intermingled, and they're all sort of contributing to some degree to their pain. So you just have to, I think, start from the place of something's wrong, right? This person would not be here if they weren't suffering from something. And then trying to make sure that we do everything we can to engage them in true expert sickle cell care. Right, there are things that can help. These medications do help reduce the rates of crisis, at least certainly hydroxyurea, crizanlizumab, and L-glutamine. So we have medicines that can help reduce the number of crises people have. But at the end of the day, it's about ensuring that they're connected with all of the resources that they need. And right, this goes back to the great question about case management. Right, we need people actively involved in monitoring patients, because especially with adults, things become very fragmented, right? In pediatrics, things tend to stay a little more contained just based on the way pediatric healthcare systems work. But once you become an adult, right, Dr. Jacob showed the map of IU health facilities. Our patients end up at all of them. And trying to ensure that we even know what's happening with our patients is a huge challenge. But ensuring that we're engaging the sickle cell team as best we can, and honestly earning back our trust from those patients. Because unfortunately, a lot of our adult patients, they have lost hope. They don't believe there's anything that can help them live better. Many of them have sort of resigned themselves to sort of the cycle of ED and inpatient stays is sort of their lives. And, you know, for those, especially our patients in like their 40s or above, when they were graduating from pediatric care, there honestly wasn't a whole lot else. There wasn't necessarily much reason for hope, unfortunately, but that's changed quite significantly. And we have to sort of build a team that can invest in earning back their trust and breaking down those cycles of mistrust that I mentioned earlier. Because there are ways to help. We just have to figure out how we can engage people, and as Dr. Jacob said, meet them where they are. As they're struggling to manage their jobs, manage their disease, manage their own families, all with potentially significantly limited social resources. It can be a struggle, but again, the foundation is starting from a place of believing patients and then doing everything we can to engage them in truly lifespan comprehensive sickle cell care.
Yeah, thank you for that. And I appreciate that piece around pain being subjective and starting from a place of just believing people, believing their stories and honoring them. So it really makes me think that there's this piece missing in the way we educate and train our future generations. You know, what are some things we can do to improve, you know, the education and training pipeline? And are there any examples in your work that you're working through or working on that might offer some promise around this particular topic?
Yes, definitely. And I think, you know, we spoke briefly earlier about how important it is to start training the future generations that will care for our patients early on. Some of the work that Dr. O'Brien, myself, and our teams have been doing, we recently received funding from the IU Black Philanthropy Circle to have a summer research program for underrepresented in medicine students, specifically focusing on sickle cell disease research. So building that interest in sickle cell disease, not just clinical care, but also research endeavors early on, in the hopes that they will continue that interest into the future and that they themselves become sickle cell experts for the sake of our patients. Another actually program that Dr. O'Brien and one of our pediatric colleagues, Dr. Megan Drayton Jackson, recently had funded is an opportunity to work with our medicine pediatric residents to build a curriculum regarding care for patients with sickle cell disease for trainees within the medicine pediatrics residency program, with the hopes of establishing better primary care and preventative care for our patients across the lifespan. So incredibly important to help build that passion early on. It's part of why Dr. O'Brien and I are here where we are. It's because that passion was fostered early in our careers, and that's what we're hoping to do for future generations within medicine. I think it's also important to begin that learning within all healthcare fields, whether it's nursing, physical therapy, nutrition. Start education about sickle cell disease early on, just like other chronic diseases are taught in those fields, because all the hands that touch our patients need to understand what our patients experience, what their disease is about, and what potential complications could come of it, so that we're delivering the best care possible to them.
And I think also just trying to undo all of the misconceptions and myths, right? We don't expect everyone to be an expert in sickle cell disease, but they at least need to acknowledge where their knowledge ends, right? And unfortunately, particularly in adult care settings, sometimes we run into a fair number of health professionals who think they know what they're doing, but unfortunately don't actually. And then our patients end up getting inappropriate care, right? And again, this is, depending on sort of the demographics of the setting you're living in, is going to be a rare disease and a small proportion of the patients you take care of. So an essential part of what we're trying to do is venues like this, just to let people know that there actually is hope and there are things we can do. We just need to make sure that all patients are getting connected with expert care, and continuing to think through right, how we provide that care, and why Dr. Jacob's work is so essential to thinking through the models by which we can provide expert care regardless of where people are.
Very nice, thank you. So we have one last question from our audience. What are ways to help reduce hospital lengths of stay for persons with sickle cell disease? Are there any emerging models of care somewhere between outpatient and inpatient services?
Yeah, so actually that's a huge focus for a variety of reasons. And there actually are strong data to support sort of an in-between model, being what is can be termed like a day hospital or acute pain infusion centers. But using, again, this sort of leads back to why the cancer center is the right place for this, right? There actually are already robust infrastructures for providing IV medications and sort of high-level medications that require significant nursing expertise in the outpatient setting, right? This is predominantly where cancer care has moved, is into the outpatient setting. And there's actually good data that using that kind of infusion center or day hospital model does lead to significantly less inpatient utilization, ED utilization, inpatient length of stay, et cetera. It's about, though, the struggle of, again, justifying the resources and getting the resources and organizing the resources to make that happen. And doing it in a way that our patients find acceptable, and again, sort of meets them where they are and what they're able to manage. Right, and that's when you're talking about a relatively resource-intensive intervention, like giving IV pain medicines and things in clinic, that requires a lot of resources, and creating a system that can do that in a very flexible way is challenging. But that's definitely something that we're working very hard to expand access to, and with the hopes of not just reducing ED and inpatient utilization, but also helping patients feel better and thrive better. Because unfortunately, many of our patients avoid using acute care settings as long as they possibly can due to unsatisfactory experiences they have had before. And so they try to delay as much as they can. And then when they do end up in the emergency room, they're all that much worse because they've been doing their best to avoid it because of the experiences they've had before. So if we can create, again, a place that's really comfortable for them and designed for them, where they can get the care that they need and can be confident they'll get the care that they need quickly and efficiently, right there, as I said, there are strong data to support that significantly reduces ED utilization. It's just a matter of building that kind of infrastructure, and that's something that we're working very hard on the clinical aspect of the Center of Excellence.
Okay, thank you. Looks like we have one last question that came in for you, Dr. Jacob. What is implementation science, and why is it important to sickle cell care?
Yeah, that's a great question. And whoever sent that in, feel free to email me and we can talk more about it, because I could talk for hours about it. There's various types of implementation science. I think the implementation science that I invest the most time in is related to my research. And the idea is essentially what we've been talking about, that there are sort of novel therapies, there are innovative sort of patient care plans, lots of ideas for ways to improve care. But if we don't implement those new ways in a way that's sustainable, that it works for both the patient and or family themselves, but also for the health system, which may either be the clinic, the inpatient unit, the hospital, or maybe all of those, then it's not something that's going to be effective. And so what implementation science does is it looks at what aspects of this novel thing is important to the patient and family. So gets patient input. It then also looks at the process itself. How do the people affected by this new thing feel about it? How do they accept it? How does the system function with this new process? And then what are the outcomes from that? Does it improve the patient's experience? Does it improve their care? Are providers satisfied with that? Does it work for the hospital system? And then the particular type of implementation science that I do and that I'm growing in my learning of, then looks at how can that information be utilized to then continue to improve the care. So it looks at cycles of implementation so that we're not just stagnant, we're constantly improving the care that we provide over time.
Thank you. Looks like we're right at time. So I am truly humbled to be in the presence of these two amazing doctors, and I am learning every single day. And I want to thank you for joining us today, and thank the audience for tuning in today. Make sure to visit us at cancer.iu.edu/Simon Says for information about our next month's presentation. As we close out, is there anything you want to share about getting involved, or things you want to just share with the audience before we close out?
And thank you for giving us this time and space to talk about sickle cell disease, especially as we're closing out Sickle Cell Awareness Month for 2022. I think it's so important that our patients and families are involved in the care that they receive, and being advocates for that care is incredibly important. Working with your community-based organizations such as the Martin Center, working with your sickle cell teams, working with us at the Center of Excellence to make sure that the care we're designing truly is for you and your family. So I think speak up, speak out, make sure that people know how important it is.
All right. Everyone, take care, and we'll see you next month.